Good morning, and thank you for the opportunity to present our state-level health promotion approach to managing the emergence of COVID next in Victoria. This response is grounded in the understanding that the success of any public health initiative depends on not only the application of biomedical measures, but the social, cultural, and structural conditions that shape people's capacity to protect themselves and others. We are also informed by the data that shows how effective measures such as mask wearing, social distancing, and hand hygiene have been in preventing early transmission, as opposed to once case numbers have already started to rise. Victoria's previous experience with COVID-19 revealed significant inequities in how priority groups, such as culturally and linguistically diverse communities, are treated in times of crisis. The 2020 hard lockdown of the Collingwood and Flemington public housing towers, particularly 33 Alfred Street, involved breakdowns in communication and messaging that resulted in distress for an already vulnerable cohort. The Victorian Ombudsman 2020 investigation found that residents were detained without warning, provided inadequate information in their languages, and subjected to a policing response that exacerbated pre-existing trauma and resulted in further mistrust of the government at a time when trust was especially crucial. To prevent a repeat of that experience, COVID Next requires a community-centred, equity-driven prevention strategy built on collaboration, trust, and clear, culturally appropriate communication. Proceeding at the state level is preferable as Victoria has the legislative authority, public health infrastructure, and local partnerships necessary to implement rapid, context-specific interventions while maintaining consistency with national and global frameworks. We are guided in our response by the socio-ecological model, which provides a structure for understanding the multiple layers influencing individual behaviour and health outcomes. At the individual level, we consider personal beliefs, health literacy, and language proficiency. Many CALD residents rely on informal information networks rather than government channels, so ensuring accuracy and accessibility at this level is crucial. CALD consumers may also have lower digital literacy and access to technology, meaning they get media from more traditional forms. They also receive information from communities in their countries of origin, which informs their views. At the interpersonal level, family and community networks play an essential role. In the 2020 towers, tight-knit families supported one another, but the misinformation also spread rapidly through these networks. Partnering with trusted community leaders and bilingual educators can harness these relationships for prevention. The community level encompasses local organisations, religious institutions, and cultural associations. These groups have direct insight into community needs and are key conduits for co-design and message distribution. Key individuals who have community trust can become champions of the cause, assisting to disseminate information in ways that resonate. At the society and policy level, structural barriers, including racism, housing insecurity, and lack of cultural competence within government, must be addressed. The Ombudsman's report highlighted how decision-making processes excluded residents, reflecting systematic inequities that erode trust. The SEM thus reminds us that to prevent disease transmission through acts such as social distancing, hand hygiene, or mask wearing, we need to cultivate environments where people feel respected, informed, and empowered to participate in these public health actions. Slide 4 is a snapshot of the cost of COVID-19 to Melbourne, and you can see that there were many impacts from the individual to the societal level. Our state-level COVID Next response prioritises the early implementation of preventative health measures, mask wearing, hand hygiene, and physical distancing. Even when case numbers remain low, evidence from both the first COVID-19 pandemic and behavioural research in Australia show that proactive prevention reduces transmission, maintains public confidence, and prevents the need for coercive interventions such as lockdowns. Thacker, Sturman, and Orton found that compliance with social distancing strongly correlated with trust in government messaging, perceived community norms, and clarity of information. When these psychosocial enablers were present, participation in distancing increased substantially. even before infection rates surged. This finding highlights that people will adapt preventative measures when psychologically ready, which is assisted by transparent, culturally relevant communication. Similarly, Quigley demonstrated that Australians' knowledge, attitudes, and practices of mask use improved dramatically once clear, consistent public health information was available, which was amplified and reinforced by trusted local leaders. The research showed that uptake of mask use was highest when guidance was delivered early, well before mandates were introduced, and when it was contextualised within community values such as care, respect, and protection of elders. For CALD communities, this underscores the need for multilingual, culturally adapted prevention campaigns at the onset of outbreaks, rather than enforcement once transmission has already escalated. From a community engagement perspective, Aubespierre emphasises that early, two-way communication channels are critical in culturally and linguistically diverse settings. Her guide, based on lessons from Queensland's refugee and migrant communities during COVID-19, found that co-developed health messages delivered by community leaders, faith leaders, and bilingual health workers significantly improved adherence to hygiene and distancing behaviours. These findings reinforce that effective prevention depends on accessibility, trust, and participation, not merely availability of information. Therefore, Victoria's health priority areas for COVID Next should integrate these lessons by launching multilingual prevention campaigns at the earliest signs of community transmission, framing messages around collective wellbeing and family protection, values that resonate deeply across CALD communities, distributing personal protection equipment and information, masks, sanitizer, and printed hygiene guides through local cultural and religious centres, training community champions to deliver consistent, culturally safe messaging that aligns with both public health evidence and community expectations. On slide 5, you can see what has been deemed the Triangle of Trust, a model developed through Centrecare FNQ for working with CALD populations. By acting preventatively and inclusively, the state can maintain low case numbers while protecting the dignity and well-being of Victoria's most diverse populations. So we have Program 1, which is Culturally Safe Community Hubs. The first program is the establishment of culturally safe communication hubs in high density and multicultural areas such as Collingwood, Dandenong, and Broadmeadows. These hubs would be co-led by local multicultural health organisations, community leaders and interpreters, supported by the Victorian Department of Health. You can see an illustration of the co-design cycle on slide 6 and a graph of the languages spoken at the towers, which provides guidance for which communities need to be approached for the hubs. Their role would be to translate prevention messages on mask use, hand hygiene, and social distancing into multiple languages and formats, including WhatsApp videos, community radio, and visual materials for residents with low literacy. Crucially, the hubs would operate as two-way channels, not just dispersing information, but also feeding community concerns back to policymakers. Program 2, Community Health Champions Network. The second initiative is a Community Health Champions Network, drawing on the success of local ambassadors during the vaccination rollout, but expanding it to prevention. Champions, respected figures within CALD communities, such as religious leaders, youth mentors, and bilingual health workers, would receive training in infection prevention, risk communication, and trauma-informed engagement. Numerous researchers have studied the value of this approach. The champions would promote protective behaviours such as mask wearing, sanitizer use, and physical distancing using culturally familiar language and platforms. By embedding prevention messages within trusted relationships, we normalise public health behaviours and reduce resistance or confusion. This model reflects the pre-seed phase of the pre-seed-proceed framework, addressing predisposing and reinforcing factors such as beliefs, attitudes, and social norms that influence behaviour. Program 3, Rapid Response and Support Teams. The third program proposes rapid response and support teams to provide immediate community-led assistance at the first sign of site-specific inclining case numbers. These teams would replace the coercive lockdown model with a supportive health-first response. They would include bilingual health workers, mental health professionals, and cultural liaisons trained in emergency outreach. They would be tasked with delivering food, hygiene supplies, and accurate information door to door while offering emotional support and translation assistance. Slide 8 includes a graphic of the CoHealth model of care. As CoHealth are already active in the area, they can assist with recruiting a wider team that are ready to be deployed. By prioritising care and communication over containment, RRSTs build trust and prevent the severe psychological and social harms that occurred in 2020, where residents described feeling trapped and criminalised. This model reflects the proceed phase, implementing and evaluating programs that address environmental and policy factors influencing health. Now to evaluation. Using the process outcome impact model, we will measure process indicators, the number of community leaders trained, languages translated, communication materials distributed, and partnerships established. Outcome indicators, changes in knowledge, reported mask use, and trust in government communication, assessed through community surveys and focus groups. And impact indicators, reduced infection rates and equitable health outcomes across CALD and non-CALD populations. The Precede-Proceed model also guides evaluation by linking activities to behavioural and environmental outcomes, ensuring interventions remain adaptive and evidence-based. Slide 9 includes images that explain how the models will be used for evaluation. The table below, included as part of the accompanying transcript, lays out in more detail how we will evaluate our response. Now, learnings from COVID-19 and the high-rise lockdown. The Victorian Ombudsman's findings from their investigation of the lockdown offer critical insights. The absence of communication in residents' languages caused confusion and fear. Preventive messages must therefore be multilingual, accessible, and co-developed with communities. The use of police enforcement rather than community engagement damaged trust and mental health. Future responses must prioritise health workers, interpreters, and peer networks over law enforcement. The lack of consultation violated principles of procedural justice and human rights. Residents were capable and willing to cooperate if treated with dignity and provided with clear information. The stigma surrounding CALD communities during the pandemic highlighted structural racism within health systems. A culturally safe approach recognises these histories and actively works to dismantle them through inclusion and transparency. Slide 11 shows the community engagement model that was created because of the lockdown. This is a valuable tool to inform our response. COVID Next presents us with an opportunity to demonstrate that effective prevention is built not on fear, but on partnership. Now for linking our approach to global and national frameworks. Barker, Reid and Schall provide a systematic framework for scaling up health interventions based on learnings from large-scale improvement initiatives in Africa. Slide 12 provides an image of this cycle and a diagram illustrating the characteristics of good governance, which is essential when scaling up a project. Henderson and Kendall note that community navigators, bilingual culturally embedded workers, have demonstrated strong effectiveness in improving health literacy and preventive behaviour among CALD groups. At a national level, these roles can be institutionalised within primary health networks and local public health units as trusted figures. These navigators can co-develop multilingual prevention materials, promote mask and hygiene compliance, and act as feedback channels between state health departments and community networks, building the trust necessary for early intervention success when case numbers remain low. Quest have found that participatory engagement is key to successful communicable disease control in low and middle income contexts. Interventions thrive when communities co-own prevention efforts. Shafiq highlights the effectiveness of community-based infection prevention programs in informal urban settlements, reinforcing that sustained impact depends on trust, peer communication, and co-designed public health delivery. Applying these lessons globally, Australia's CALD-centred approach can contribute to WHO's global framework for community-led epidemic preparedness, ensuring equitable access and inclusion across linguistic and cultural lines. In summary, the COVID Next approach positions CALD communities as partners, not passive recipients. It balances the government's responsibility to ensure community safety with the need for human dignity. It moves beyond the mistakes of the past, from enforced isolation to informed collaboration, and builds a sustainable, culturally safe public health system capable of responding with compassion and effectiveness. By embedding co-design, multilingual communication, and community leadership at every level, Victoria can protect its residents, uphold human rights, and set a global benchmark for equitable pandemic prevention. Thank you again for your time today. I've included the references for this report in the PowerPoint and the transcript that will be provided. Now we have time for some questions.